This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
So it's my great pleasure to introduce my colleague, Dr. Dave Buckley. He's going to discuss the management of common cardiac lesions in the first 24 hours. Dave's well qualified to talk about this subject. He currently works as a paediatric intensivist and paediatric cardiac anaesthetist at Starship Children's Hospital in Auckland here. He has extensive experience in the management of congenital heart disease at all stages of management, and he regularly teaches on these subjects and is very good at it. He's also an ECMO specialist and an expert in airway and ventilation management and transport medicine. So, Dave.
Thanks everyone for turning up. It's a beautiful day outside. I'm feeling pretty nervy about the rugby, so I won't mention it, but I am nervy. I'm going to talk about congenital heart disease, and it's a weird thing. Like almost all of the stuff that we see in the neonatal period now is diagnosed antenatally, so a lot of that stuff you're not going to see in your practice. But at the other end of the spectrum, the amount of adults with palliated or operated on congenital heart disease is going up, and that is the biggest increasing group. You know, the incidence is staying the same, under 18 staying about the same, but in the adult, the numbers of people walking around with adult congenital heart disease is huge, and it's increasing every year. Probably because they do such a good job, I suppose. I like this slide. It's like it takes a while to get this thing loaded and going, and just fiddling around trying to get it working. What I have done is I've decided to divide it up into neonatal, pediatric, and adult, and a lot of, as I said, a lot of the neonatal stuff you're not going to see. Occasionally you do see it, and we have a steady stream of kids who present late with a sort of neonatal infant condition that hasn't been diagnosed around the time of birth. And like all things that come into ICU, we tend to be good at acute resuscitation, and that's what the basis of their first 24 hours is, to resuscitate them. Often you need to obtain some access. If you're not used to dealing with small kids, we do a lot of intraosseous. Like if they come in, they're shocked, they're clapped out. Everyone's really nervous about trying to get lines and get access to them. With those little drills these days, you can just do that in about 30 seconds. So we do a lot of initial IO access, and then following that, once you resuscitate the patient and get some central access. We use a lot, like I suppose compared to adult medicine, like calcium and bicarbonate are not dirty words. We use a lot of bicarbonate for people who are acidosis. With severe acidosis, and we use a lot of calcium in neonates as an inotrope, and they're two very effective drugs. Find that when kids get clapped out and they're very acidotic, as neonates or infants, their heart tends not to work so well. But often some bicarb is a good thing to have up your sleeve. We do a lot of NERS monitoring in our unit. I know there's a lot of controversy about whether or not that's a reliable or a good thing. We've done quite a lot of work on it and found that the NERS will often track the central venous saturation pretty well. So we do rely in infants, neonates and small children on using the NERS and tracking that. And often, even though you may not be able to, without surgery you can't correct the problem, but there are a number of things that you can do, how you ventilate the patient, what drugs you put them on that can ameliorate the situation and get the patient stable enough so they can be transferred somewhere where they can have surgery. The two presentations of the neonate with congenital heart disease are usually, innocent murmur, which may not indicate some severe underlying cardiac condition. The two things that we see are the kids are either blue or they're shocked. And when I sort of started doing this, I was surprised that congenital heart disease is the commonest cause of a shock in a neonate up until about the second or third week of age. So kids who turn up, they go, they're born, they go home, they come back a week later. If they're really shocked and clapped out, the commonest cause of that is not sepsis, it's congenital heart disease. And why do they do that? Well, they do it because they've got some duct-dependent systemic circulation. So they're born, they're okay when they're born, their ducts open. Over the next 2, 3, 4, sometimes 5, 6 days, the duct shuts, and when the duct shuts, they lose the ability to pump blood around their body. So they've got lots of blood that's going to their lungs, no blood around the body. And it's quite, they can present over a number of days, so sometimes they don't present suddenly. They've sort of been slightly unwell the day before, they turn up, and then by the time you see them, you know, they've got a pH of 6.8, they're anuric, their liver function's starting to go off, and often they're dreadful. You know, they've got a heart rate of 190, 200. But they at that stage are quite resuscitatable if you can just open their duct again. The treatment for them is obviously resuscitate them, never forget the glucose, and start them on some prostin. In most neonatal cardiac conditions that present acutely, you cannot go wrong by giving them prostin. Okay, so they're either blue because the duct shut, or they're shocked because the duct shut. If you open the duct with some prostaglandin, you're doing yourself a world of good. The other presentation, they have a duct-dependent pulmonary circulation, so the duct shuts and they get no blood going to the lungs. And they can be blue as a badger, but they're not making effort to breathe unless they become quite acidotic. So they lie there quite peacefully. Someone puts a pulse oximeter on, they've got a saturation of 60, 65 maybe. I mean, obviously they've got to have some blood that's going through the lungs and getting back to the heart and going around the body, otherwise they'll be dead. But often they mainly rely on the duct. They have some other form of pulmonary blood flow, like some aortopulmonary collateral, so they do get some pulmonary blood flow, but they're often quite blue. And then, you know, compared to having a respiratory condition, they're not making a lot of effort to breathe. So they're not blue because they're struggling to breathe, they're blue because they've got no blood going to their lungs. And again, the treatment of them is obviously give them oxygen. You know, and it's amazing how much difference some oxygen can make. It shouldn't, because it's all shunt, it's not blood that's going to a bad set of lungs. So, but often oxygen will increase their saturations a little bit. And obviously, again, put them on some prostaglandin, open the duct. Oh, sorry. I just say we do see the odd baby, and like who presents at like 4 weeks, 5 weeks, 6 weeks, and they're blue. No one's noticed that they're blue. They might have dark skin, or they just don't look that blue, and they turn up. Sometimes they've got some associated respiratory condition, or they're not feeding well. Someone puts a pulse oximeter on them, and they've got a saturation at 70. And like it's not that they've developed that, they've been like that since birth. And the commonest thing for that is the transposition babies. You know, they're usually term babies, they look perfectly well. They look maybe a little bit blue, and then that goes away. No one measures their sat, and then a month later they turn up with saturations that are in the 70s. At that stage, like, prostaglandin is not going to help them, because the duct by then will not be openable. I mean, it might already be open, they just don't get enough mixing, but you're not going to open the duct by giving them prostin at a month of age. And then the pediatric conditions, the commonest one we see by far, congestive heart failure, and we see that for a number of reasons. The commonest one is a kid who may or may not have been diagnosed with with either patent ductus arteriosus or a big perimembranous VSD, and they turn up usually sort of when they're 2, 3, 4 months old, either because they get some concurrent respiratory infection, or they're just by that stage, it's when about their PVR is low, the hemoglobin's low, so they just get increasing amounts of pulmonary blood flow. And the other things are, you know, sometimes hypoxia, sometimes arrhythmia. We do see a number of kids who have cardiac arrest, like John Skinner talked yesterday about, you know, sudden death in children. So we see that cardiac arrest thing. Almost all of the cardiac arrests that we see in a unit are unrelated to a cardiac condition, but some cardiac conditions can present like that. And then there's a lot of non-cardiac causes of cardiac problems, you know, which I'll talk about a little bit. So congestive heart failure, as I said, the commonest cause is large shunt. So you get a PDA or you get a VSD, the blood shunts from the left side of the heart to the right side of the heart and all comes back to the left side of the heart. So you get left ventricular dilatation. chest x-ray, big heart, wet-looking lungs. Sometimes it's hard to tell because they might have some intercurrent respiratory infection. You listen to them, you can hear a murmur, or you might not. But often the giveaway is that they have a history of, for a day or two they've been sweaty with feeding and not feeding quite so well. You examine them and they've got a big liver. And sometimes if they've got sort of bronchiolitis / asthma type condition, the lungs are hyperinflated, the liver's pushed down, and you can be fooled a little bit, but usually the liver is massive, like 5 centimetres below, big bulky thing. We see a lot of rheumatic heart disease in the country, and they can present, with a severe mitral regurgitation, aortic regurgitation, but often in the older kid, like 8 years, 10 years, 12 years. And we do see a number of those. They tend to have a much sort of longer course and present at an older age. And then there's a weird and rare things. We have sort of runs of cardiomyopathy, myocarditis. I don't know what's in the water, but we have little patches of that, and they present with heart failure. They can present with sort of arrhythmia, and they can be quite difficult to manage. And then there's the things like, abnormal coronary arteries caused by either Kawasaki disease or a congenital coronary artery that comes off your pulmonary artery. They usually sort of infarct their left ventricle and present with heart failure. And then some kids have sort of chronic arrhythmias, particularly neonates. They've been in SVT for weeks, and then if you stay in a sort of SVT for long enough, you get a sort of rhythm or rate-induced cardiomyopathy. So the thing about them is that you think, I'll zap them and they'll come out of that rhythm and they'll be back to normal, but often you get them out of the rhythm and the function of the heart remains poor. It does recover, but it can take a number of days or weeks. What's that slide? So, yeah, it's hard to know. They turn up in heart failure. Often they benefit, often it's left heart failure, so they do benefit from some positive pressure. So a lot of the time we put them on high flow. Occasionally we have to intubate and ventilate them. And they can be, the myocarditis with the really poorly functioning heart can be a difficult thing. They're better on the ventilator, but they're pretty ropey sometimes to get onto the ventilator. So give them some fentanyl, have some adrenaline drawn up, maybe start them on a little bit of adrenaline before you even embark on it. Give them small dose of fentanyl, small dose of muscle relaxant, intubate them, don't over-ventilate them, don't under-ventilate them, and be prepared to bolus them with little doses of adrenaline. I usually find that works. But again, as I said, it's the same in adults who have really poor myocardial function. And we do see a reasonable amount of that, as I said, in the myocarditis or the cardiomyopathy that presents in sort of kids that are 6 weeks, 2 months old. It has a surprisingly good long-term outcome if you can keep them alive long enough for the heart to recover. Hypoxia, as I said, it's rare outside of infancy. You can get it. What do I say about that? I suppose the thing is, people have been palliated what's an acceptable saturation. So if someone turns up, their saturation's 75%, it might normally be 75%. And so we see a lot of kids, they've got a shunt or whatever they've got, that's their normal saturation. They live with a sat of 75 or 80%. They run around normally. They might desat a bit more when they exercise, but they're perfectly fine. Give them a little bit of oxygen if you want to, but often they're quite happy at that. And if you don't know what their underlying saturation is, it's quite nerving sometimes. You think, they're setting at 65 and their mother says, that's what they always are. It's okay then. But, and they do okay. Sometimes though, they have some palliated condition. They've got normally a lowest saturation and they develop bronchiolitis. They develop something on top of it. And they're kids who, they can be tricky to manage because you've got to sort of manage the other condition in order to make their saturation, their cardiac function better. And sometimes they don't have, they present with diseases that aren't related to their heart disease. So we're treating them for something else totally unrelated to their heart disease, which can be, you've got to sort of manage two things in parallel. And, you know, like, people go, oh, you shouldn't, you know, there's some babies that you shouldn't give oxygen to. I mean, anyone who's hypoxic should get oxygen. I mean, that's what we do. I mean, of course, you don't want to give them too much oxygen, but if they're hypoxic, give them oxygen. It's pretty basic. And then, you know, like, as I said, you've got to think, what is an acceptable saturation? And I don't know what an acceptable saturation is, but I do know there's lots of small kids running around out there who saturate in the mid-70s, low 70s, and they do it for month after month after month. I don't know if they're going to be rocket scientists or not, but they seem okay, and they seem to develop okay, and the long-term follow-up of them they don't, you know, they're not, as Tom said yesterday, they're maybe slightly below the sort of median IQ for us, or, you know, for a standard population, but they're not too bad. Arrhythmia, as I said, like, arrhythmia is a funny thing. Like, the kids turn up, and we have a number of kids who come from other places. They're incredibly unwell. They've got a rapid heart rate, and the question is it SVT? Is it sinus tachy because they're unwell? Is the tachycardia making them unwell? Is the tachycardia a reflection that they are so unwell? And often the safest thing to do is consider that it's sinus tachy because they've got some underlying other condition and manage that. We've had the odd kid who's sort of gone down the SVT pathway when it hasn't been SVT. And you know, you can give them adenosine like anything else. You cannot give them, well, you should not give them a beta blocker or a calcium channel blocker, because both of those things can be very negatively inotropic for the neonatal infant heart. And, you know, the cardiologists are constantly being rung at our hospital from around the country. You can send ECGs via phone or fax, and they're more than willing to, you know, your local pediatric hospital, fax them or email them a 12-lead ECG, get some advice is probably the best thing to do. Cardiac arrest, I mean, by far the commonest cause of cardiac arrest is a respiratory condition in the pediatric world, which is why they do so badly, because by the time their heart's stopped because of a lack of oxygen, they've had a prolonged period of hypoxic, and they get a severe hypoxic ischemic injury. The commonest cardiac, people have a primary cardiac arrest. Most of them have a known cardiac condition, but there are a number of things like long QT, Brigadia, you know, that catecholamine-induced ventricular tachycardia. Those things can present de novo and otherwise perfectly well children. And if someone has a cardiac arrest and they've been documented to be in VT or VF, they need further investigation as to if they've got one of these underlying arrhythmogenic problems. And some of the myocarditis that we see, they present not with heart failure, they present with VT, or they present with a funny rhythm. They get really, so the conduction system of the heart seems to be more affected than the pumping function of the heart. And we've had a couple of those that we've had to put on ECMO, not because the heart was failing, because we couldn't get them out of the persistent VT or VF. And then there's a whole list of, you know, like, we echo people, so we get some kids come in, they've got septic shock. You echo them, the heart function dreadful. Cardiologist says, or maybe they've got some underlying cardiac problem. They get better from their sepsis and their heart function picks up. Or they've got bad bronchiolitis sometimes, but, you know, or bad bronchopneumonia. You echo them, the right heart function looks dreadful. People go, oh, they've got pulmonary hypertension. You go, well, yes, they have, but they've only got that because their lungs are so bad. You cure their lung condition and the right ventricle gets better. And, you know, cardiac arrest, same as the adult thing. As I said, you need a 12-lead ECG, and you need to make sure that it's done at normothermia and the electrolytes are okay. You need to look at that to see if they've got any evidence of some underlying cardiac rhythm problem. And then there's all these kids that they've been palliated, they're walking around in the community. As I said, they might be running around with SATs in the 70s. Often they'll have a hemoglobin that's 170 or 180, so they need to be well hydrated at all times. The right ventricle doesn't like being hypoxic. They get a lot of diastolic dysfunction, so the function of the heart, if you echo them, is really good, like it's cranking away, but the heart cannot relax and fill up. And we see a lot of, they have a sort of CVP that sits around 10, 12, you know, so it's diastolic function. You put those kids on catecholamines or some sort of inotrope, the thing just gets stiffer and stiffer and stiffer. You can't fill up, like it's pumping really well. It's got really small tidal volume, really small volume, stroke volume, sorry. And then, you know, like if the ventricle has been pressure or volume overloaded for a long time, like a single ventricle thing that's been palliated, sometimes that ventricle won't recover. So some kids who've had a transannular patch for tetralogy repair, or they've had a big shunt for a long time, ventricle gets stretched. You take the load off it. You can't take all the load off it because it won't work. It needs some stretch. But sometimes it's been so stretched up that it cannot recover and get back to being having normal function. You know, and there's a number of syndromes that have cardiac anomalies associated with them so commonly that when you hear that someone's got that syndrome, you just go, yes, I know they're going to have a cardiac condition. The one that's the one to be really scary about is the Williams syndrome kids. They have, you know, they have multiple arterial abnormalities. The thing that we see them for, and they get into major trouble with, is their supravalvular aortic stenosis, abnormal coronary origins, and we've had 3 or 4 of those who've done badly. And a couple of the other ones have had sort of mid-aortic syndromes, like and renal artery stenoses. It's a multiple sort of arteriopathy. And as I said before, you look at that graph, you can see the numbers are static for the numbers being born with congenital heart disease, small kids being treated with heart disease up to 18 with congenital heart disease, but the adults above 18 is exponentially, well, it's going up at quite a steep rate. I'll just talk about some of the things you might see for the adults. So ASD, you won't see it. They present in their 50s, 40s usually. They might have had a stroke, but often they just get tired. They go to their GP, they're not feeling, they can't walk up steps like they used to. GP does, you know, has a listen, might hear a fixed splitting of a second heart sound, send them for an echo, they've got a big ASD. They go to the cath lab usually, they get a device put in, and that's the end of the story. Okay. The VSD, I've got a woman I'm going to do on Monday she's 54 and she's just been diagnosed with the VSD. It's obviously not a very big one, but you know, they go to theatre, they want to close it because obviously there's a risk of stroke, there's a risk of getting bacterial endocarditis. So if you find it, you've got to treat it. PDA, we see a number of sort of kids who are 10, 11, 12, bad heart failure, and they've had a PDA that's been missed since birth. Aortic stenosis, you know, people who have coarctation, a high percentage of them have a bicuspid aortic valve, so a high percentage of them are going to present as adults with aortic stenosis and need surgery. At our hospital, we do all those patients because they count as adult congenital. So at a lot of other hospitals, they're done by adult surgeons doing aortic valve replacement. And coarctation, adult coarctation, it's an ugly disease. They get all these collaterals, you know, that massive, when they operate on them, it's really difficult to repair the aorta. We don't do primary ballooning and stenting, but we do, like a lot of kids who've had a coart repair, they'll get a recoarctation and they get ballooned and stented in the cath lab. Tetralogy, that's probably our commonest operation, putting in a pulmonary homograft or a pulmonary valve in kids who've had a transannular patch. So they've had their tetralogy repair, they've cut through the pulmonary valve, opened it up, put a patch in there so they've got free PR. They last till they're in their 20s, 30s sometimes, and then they get from the free PR, the RV dilates up, gets to a certain size, they need a valve put in. That was the origin of the percutaneous valve, was the Melody valve, which you put in like the aortic ones, except obviously not in that position. And they've had a really good record, but we sort of go through patches of using them, patches of doing a pulmonary homograft. Ebsteins, they can present with arrhythmia when they're old. They get, you know, atrialization of the right ventricle, so massive heart, like wall-to-wall heart, big right atrium, lots of arrhythmias usually. And then TGA, like there's a DTGA and the LTGA, there's a corrected transposition whereby all the plumbing's sort of right, except your right ventricle and your left ventricle are on opposite sides. They often have a VSD and some pulmonary stenosis, but they can present like when they're 20, 30, 40. They get a lot of complete heart block that sort of comes on over a number of years. And then, when they're that age, you're thinking, what am I going to do? Am I going to leave them alone, or am I going to do some complicated cardiac surgery? Because often they're feeling quite well. They're not sick. And then the horrible, the fontan. You don't want to go anywhere near these patients. Once the fontan starts failing, it's an ugly, ugly thing to deal with. Like the positive pressure's bad, negative pressure's good. Often it's got nothing to do with the heart. The heart you need to optimise the lungs and the intrathoracic pressure and get the venous pressure under control. It's not the function of the heart. The heart's failing, but it's failing because it's got problems with preload and afterload that need fixing rather than sort of fixing the heart. Oh, that's my last slide. We're having questions at the end. Okay, thank you.